Thank you very much. Good afternoon, good evening now. And I'd like to thank Professor D'Souza and the whole NSL team for having me here. So what I'm going to do over the next 15 minutes is talk about prediction. The spelling has gone wrong as well. So, and prevention of post-hepatectomy liver failure. So post-hepatectomy liver failure is seen about 10% of major hepatectomy, and it is a cause of mortality of nearly 60 to 100% after hepatectomy. And prediction and prevention is the best strategy. Once established, it's difficult to salvage. So prediction and prevention actually goes in hand, and that's what I'm going to do. I'm going to discuss few cases and how to go about in those situations actually. So when we look at the guidelines, most of the guidelines for safe liver resection actually focuses on remnant liver volume. So they suggest when you have a normal liver, it's about 20% of total liver volume. When you have an injured liver, that is MAFLD, CASH or cholangitis, cholestasis, then it's about 30% of total liver volume. And if you have got a diseased liver like extensive fibrosis and cirrhosis, it's about 40% of total liver volume. So, but when we look at when we go down further into this, it's not just about volume. There are many more factors which actually plays part in terms of predicting post-hepatectomy liver failure. So the focus on volume is actually somewhat not very relevant, and it also involves lots of other things, that is extent of resection, quantity and quality of liver parenchyma, so that is determined by the age. Again, MAFLD, when you have CASH, chemotherapy-induced steatohepatitis, fibrosis, cirrhosis. Then vascularity of liver is very important. So if you're going to live ischemic or congested segment, even if you have big volumes, these livers are not going to regenerate and cause problem. Then again, cholestasis, cholangitis is an important risk factor. And in patient with CLD, we see so commonly now, especially in patient with hepatitis B and NASH as well. So you need to evaluate degree of portal hypertension as well. So these are major factors associated with post-hepatectomy liver failure, and it's all about ability of liver to regenerate, which again comes down to volume and function of liver in order to have an optimal liver regeneration. So we have quite a bit of interest in terms of how the liver regeneration happens in donors, and we did this study to see what are the factors which determines liver regeneration in donors. And what we found was the extent of liver resection actually do determine. So if you're doing a left lateral segment, then the volume restoration is not much. But if you're taking a right lobe, then naturally there is more liver regeneration and more volume restoration happens in those group of patients. The other part of the story in this interesting paper was when you have an AST level which is higher than at the higher end of the normal range, again the liver regeneration is affected. So even a minimal damage into liver parenchyma, which is with high ALT levels, can actually affect the liver regeneration and growth of the remnant as well. So it becomes important to optimize this livers as much as possible. So we went on and did this randomized control trial to look at whether if we do a lifestyle optimization on healthy normal donors with less than 5% steatosis, and what happens to their liver regeneration in terms of recovery of biochemical function, restoration of volume, and also on the graft function in the recipient as well. So what we found was there was a good weight loss, and the normalization of bilirubin was earlier, and INR was also normalized earlier as well. The AST levels were lower as well, and again the liver regeneration on day 14 was much better in donors who had optimization protocol. And this was actually backed up with markers of liver regeneration as well, and then early graft dysfunction rate in the recipient as well were lower as well, and their ICU stay was lower as well. So this just shows that there is so much capacity within the liver and within normal livers as well, so-called normal livers, for them to regenerate, and those capacities need to be utilized in order to prevent post-hepatectomy liver failure. Then again, coming down to volumetry, because most of the focus come down to volumes of the liver. And again, there are lots of now software available to do volumetries. And this we actually tried to see whether simple 2D volumetry is equivalent to a 3D or a sophistication apps which are now being used. and we found that there's no difference in terms of using sophisticated apps for this, and a simple console 2D volumetry is good enough as well. And then I'm just going to take you through this case. 71-year-old male with a large HCC in the right lobe of liver. His ICG, which we normally do in all the patient, was 4, and he didn't have any varices. So his volumetry was, total liver volume was about 2,300. So you need to always subtract the tumor volume from the total liver volume as well. So tumor-free volume was about 1000 ml, and he was planned to have a right hepatectomy, and his left lobe volume was about 360 ml as well. So the calculation wise, it was about 34%. He underwent a right hepatectomy with an anterior approach and then made an uneventful recovery. So these are important things when you're looking at volumetry, that tumor volume need to be subtracted, what will be the extent of the section, whether you're going to save middle vein or not, and those actually determines what will be the outcome. So this was unifocal HCC, these are just intraoperative photographs, this is postoperative follow-up CT scan as well. Coming down to cholangitis and cholestasis, these are a very important determinant. Again, I'm going to take you through a case, 38-year-old female with gallbladder cancer, hilar block. She had an ERCP and a stenting because her bilirubin was 21. ICG after the bilirubin come down was 3, and her bilirubin at the time of surgery was 3 milligram DA. So this is her scan. You can see there is a hilar block, IHB, BRD involving the hilum as well. So she was planned to have an extended right hepatectomy. Her left lateral segment was about 33%. One would have thought this is okay to go ahead in a young patient. And this was her intraoperative photograph. You can see there's still cholestasis there, and the liver appears fatty as well. We did an extended right hepatectomy with Roux-en-Y reconstruction. Post-operative, she did have a liver failure, grade C as well, with sepsis, bilateral pneumonia, prolonged mechanical ventilation. She had a wound dehiscence, but ultimately she recovered and discharged on day 14. Her normal liver biopsy was steatohepatitis with portal and perisinusoidal fibrosis as well. So this again just shows that you need to evaluate properly. One would have thought a young patient with a good remnant will sail through this operation, but that's not the case. You have to actually take every index patient accordingly and evaluate them properly as well. So this is just to show the data on impact of pre-op jaundice and cholangitis. They are major determinant of post-op hepatic insufficiency and mortality as well. So coming to chronic liver disease, most people will think that portal hypertension is a contraindication for liver resection, but that's not the case. There's a lot of data actually on patient undergoing liver resection for HCC with portal hypertension, and on propensity matching actually it shows that the survival and the survival are similar as well. So when you are assessing a patient with CLD, it's important to assess in terms of clinically significant portal hypertension, and that is determined with an HPVG of more than 10, ascites, splenomegaly, platelet count of less than 100, and arpeggio showing varices as well. CTP and MELD are very commonly used. If you've got a CTP of A, then you're okay. And if you're CTP B and beyond, then there's a higher risk in them. In cases where you are late CTP A and early B, that's where the situation is bit gray, and how to evaluate them becomes a concern. So ICG can help. And again, there's a lot of data on HPVG as well. I've just put on this slide to say that HPVG is always not good to evaluate in terms of you may lose out on patient who can benefit from resection. So this was a study published in Journal of Hepatology, and 70 patients there, 17 of this patient who had a high HPVG had an uneventful recovery as well. So you should not base your decision on a single reading of HPVG, and especially in tumors like this, where you're trying to wedge a pressure and see how much will be the portal pressure. It cannot be right there as well. So don't exclude patient based on single reading of HPVG as well. Functional assessment, again, it is important. ICG has become very common. If you have an ICG clearance of more than 15 major hepatectomy is a bit of it can be a mess. So you need to be careful there if you're planning a major hepatectomy with an ICG clearance of more than 15%. And nowadays scintigraphy has come, and there are lots of centers, not much available in India, but you can do functional studies and you can actually show the functions of the remnant as well. These are not commonly available, but this can be good tools to assess as well. Whenever in doubt, do a biopsy and non-tumorous liver biopsy, and it can show you what if the extent of steatohepatitis, fibrosis. There is no harm in doing it. It's better actually to be upfront, knowing what exactly the remnant parenchymal looks like, rather than actually regretting later on. So what to do when you have inadequate volumes? So this is again a patient with hilar cholangiocarcinoma type 3A, maximum bilirubin was 13, and the volumetry shows left lateral segment was about 265 cc, that was about 18% of the remnant liver volume. So we did a left PTBT on him and right portal vein embolization. So there was a good growth on the left side. The left lateral volume increased to 39%. It was about more than 600 ml as well. So that's just to show the portal vein embolization and the left PTBT there as well. And he underwent an extended right hepatectomy with chordate lobectomy and segmental resection of main portal vein as well, and excision of the extrahepatic biliary tree as well. So the biopsy showed moderately differentiated perihilar adenocarcinoma, background liver, there was no statosis, increased periportal fibrosis, although he did had a prolonged hospital stay of more than 4 weeks of ascites formation that may be related to the portal vein resection as well. So this is how you can enhance the volume. And one of the things about portal vein embolization is when you are enhancing the volume, that you can look at the kinetic growth rate. So you can when you re-image them at about 3 weeks or 4 weeks after portal vein embolization, then you can actually assess how much has the growth happened. So if the growth rate is not good enough, which is less than 2%, then they are at a higher risk of hepatic insufficiency, and they are associated with high morbidity and mortality as well. So it gives you a good tool in terms of assessment patient. If there is a good growth and growth rate is good, then you can take them. If the growth rate is not good, then actually you should think about whether you should put them for a major liver resection or not. Then there are other ways of enhancing the volume. So this is a lady, 60-year-old lady with multifocal hepatic hemangioendotheliomas in the right lobe of the liver, segment 5, 6, 7, and 8. She had a history of methotrexate for about 15 years, and this was scattered lesion in the right lobe of the liver. And her volumetry actually suggested left lobe was about 37%. We thought that it should be okay to go ahead, and the volume wise also it looked good. But when we went in, this is the liver looked like. So you can see clearly there is a lot of statosis there, and we were not very happy with the look of this liver. So what we did was we actually ligated the portal vein and did the parenchymal transection here. So we divided the parenchymal transection, ligated the portal vein and left it like this, and then we waited for 7 days for liver to get hypertrophic, and then we went in again in second stage and resected. This is after this is going back at the second stage, and you can see there's a good hypertrophy of the left lobe there, and then we resected out the right lobe there. So this is a procedure called ALPS, which is commonly used as well, and but it is more commonly used as a rescue procedure rather than actually an alternate for portal vein embolization. So that was her final histopathology, multifocal epithelioid hemangioendothelioma, and she did had a macrovascular statosis as well. So this is the last bit. I think this is because I just put in this because I thought there were lots of PG students as well. So it's about liver regeneration in partial hepatectomy. So this is different from what happens in acute liver injury in terms of hepatitis and other sorts of liver injuries. So the way liver grows after partial hepatectomy is a very different thing than the acute liver injuries. So most of the time what happens is there is a sinusoidal stretch because there is an increased portal flow in the remnant liver, and this sinusoidal stretch actually leads to cell going into mitosis, and then the liver regenerates. The Cooper cell, stellate cell and all get activated, and that's how the liver regenerates. And then the whole philosophy about this is about portal hyperperfusion. So if you look at the model like this, there was a portal flow which was going to about 1.5 grams or 1.5 kgs of liver. Suddenly it has been diverted towards the 400 or 500 grams of liver. So this portal hyperperfusion actually causes a shear stress. It disturbs the microcirculation, leads to ischemia and hepatocyte damage. There is hepatic artery vasospasm as well, and then there is a congestion on the venous side as well, and that's what lead to liver dysfunction and failure. So this whole theory actually looks very good, and you would have thought, yeah, this is good to buy on, and this is how it works. And then you would have thought that if you modulate the portal flow, then maybe you can prevent this shear stress, and maybe you can prevent the injury to the liver. But then we did some of this work on this, that whether actually diverting the portal flow or reducing the portal flow can prevent the injury to the liver. And this was in the setting of, this is my last actually, this last bit. I'm not going to take more than 45 seconds. Okay. So when you ligate the splenic artery, the portal flow gets reduced, and you would have thought reduced portal flow will have a reduced sinusoidal injury, and the liver will regenerate better. But what we found that it doesn't really benefit. So in terms of understanding for portal hemodynamics after liver resections and after transplantation, we still need a lot of I'll say it is still in infancy. We need to understand this much better in order to come up with better algorithms of managing this. So this is my final slide, prediction and prevention of post-hepatectomy liver failure. So you need to assess all the risk factors, that is age and BMI, and look at the liver parenchyma in whatever possible ways in order to make sure that you're not dealing with a bad liver. There are lots of imaging modalities nowadays available. Ultrasound, fibrous can tell you a lot. CTs can give you the volumetry. Then you need to do a functional assessment with ICG and scintigraphy. If the FLR is low, about 20-30%, then you can achieve a good growth with portal vein embolization. And if the FLR is less than 20%, then you can consider complete venous deprivation. That is basically you do the portal vein embolization as well, and you embolize the hepatic vein as well. That can achieve more hypertrophy, and then you can plan rescue apps as well. So that's my take home. An adequate liver volume is needed to prevent post-hepatectomy liver failure. Just volumes are not good enough. Need to assess function as well. Short period of lifestyle optimization can improve liver regeneration and safety of liver resections. Both PVE, ALPS and LVD can increase resectability rate and safety of liver resections. Each patient should be individualized and assessed to prevent post-hepatectomy liver failure. Thank you very much. Thanks a lot.